Welcome, everyone. I hope you are doing very, very well today. Can everybody hear me okay?
Yes.
Fantastic.
Yes.
Thank you so much.
Yes.
Thank
Yes,
you
you
for
can
joining.
hear you.
Yes, madam. Thank you.
Thank you so much. Welcome, everyone, and thank you for joining us today for our third session of Boosting Leadership to Advance Life Course Immunization. We're so grateful to have you with us here today. Our prompt this morning was a question that seems easy on the surface, but is actually pretty complicated. We asked, who are you? And what I'm seeing from the chat is we have folks who are introducing themselves by name and by country, or their role as well. Folks are saying where they are viewing this from. We have participants from Haiti, Somalia, Pakistan, Indonesia. Adora says, I am a vaccination advocate. And I love that people are bringing different perspectives to this. Some are saying, I'm my name, I'm coming from this place. I know I tend to often introduce myself in a similar way and say where I'm coming from, or where I was born and raised. That's part of who I am. Also, what I do is part of who I am. And it looks like folks are responding in a similar way, both sharing where they're coming from, what they care about, and also what they do with their professional role. And there's that difference, right, between professional role and what you're passionate about or what your purpose is, and those things can be connected. And folks are giving us a little bit of all of those different perspectives on the question, who am I? So thank you so much for sharing in the chat some of those introductions. It's great to see some familiar faces and names, and I hope you have had a great day so far, and that you all have a great rest of your day. I want to share our agenda for today. We are going to be going through a very brief review of what we learned in last week's session and in this week's EDAP module, which you had as pre-work for before this session. And then Nook will be facilitating a session on identifying your key stakeholders. Marianne will be sharing a case study on determining the vaccine target population, disease burden, and surveillance, in this case related to the target population of pregnant women and Tdap. We are going to be then using that case study to practice the stakeholder factional mapping Nook will be introducing, and then we'll come back together for debrief, checkout, and homework. So I'm going to move through these slides quickly, as we did a full introduction in our course launch, and by this time you know all of our names and faces very well. This is our project team. We also have a fantastic cohort of Boost Champion facilitators who are on board to support you and your learning, as well as our technical advisors who are, sort of with us throughout this series. So I encourage you to read into those introductions if you have not already in the session 1 recording, and also feel free to reach out to us on the Boost Learning Group, where we are all sort of identified in that online learning group. So we welcome engagement there as well. So to start off, these are some review and key takeaways. So the review of the previous session and the key takeaways from the EDAP module. These are linked, so when you receive the slide deck, you'll be able to link straight through to previous session and that EDAP module. But first, I want to situate us in time a bit in this journey of this course journey. So we are here November 2nd, the third session. We have gone through the course kickoff and the introduction to life course immunization. Today, as I said, determining the vaccine target population, disease burden, and surveillance. It's our technical topic. And then the adaptive concepts that we are really going to be leaning into are about thinking politically, 6 key relationships and values, loyalties, and losses of the different relationships. Next week, we'll be getting into building vaccine acceptance and demand. So a quick review of last session. In the introduction to life course immunization, our technical advisors provided an overview and introduction of life course immunization, the meaning and significance of life course immunization, or LCI, recommendations regarding life course immunization and pipeline vaccines, key considerations when transitioning to a life course immunization approach. And then Marion provided an example of these concepts in action by sharing the example of HPV vaccination in South Africa. Then it took us through some key concepts in adaptive leadership, getting on the balcony, gaining the perspective to understand the patterns that can be difficult to see when you're sort of in the thick of things, when you're too close, framing the gap between the aspiration of what we hope for with life course immunization and the current reality where you are, and finally the difference between technical and adaptive challenges. So that was a little bit about what we worked through in last week's session. And then you were also asked, as I said, to complete an EDAP module on determining the vaccine target population and disease burden and surveillance as pre-work for this session. So I want to very briefly review the key takeaways from that module, which we'll be going to more in depth in a particular case study. So we're not going to go into it too much right now because you had it in the module, and we'll also be going in more depth, but I wanted to provide a bit of some key takeaways. So first, identifying who you are targeting and why is one of the very first pillars of life course immunization, and targeting will be increasingly important. Those are some of the key takeaways from that module. The EDAP module also goes into the importance of tracking and surveillance data to help reach target populations and to inform decision-making at the local, national, and global level. And finally, there are some key considerations. And as I said, the EDAP module goes into more depth, and Marion is going to be going into more depth about this as well. But there are some key considerations when introducing a new vaccine: the burden of the disease and the priority of that disease. There is the vaccine's safety, efficacy, availability, and cost effectiveness, and the strength of the health system to roll out and deliver the vaccine over the long term. So again, once these have been considered, a crucial next step when rolling out a new vaccine or target population is to identify the key stakeholders and how to approach and manage the relationship with those stakeholders. So these things are very connected. This is a very key next step in this process, which is why I'm happy to now turn things over to Nook for our next topic, which is identifying key stakeholders and factional mapping. So over to you.
Thank you, Elizabeth. And welcome to everyone. It's wonderful to have you for a third session. It's always interesting to see how people incorporate some of this language that we're using here in the platforms that you have. I've seen people comment on LinkedIn. I've seen the Boost platform, the WhatsApp platform. So continue to internalize some of this work. And the thing is, if you stay on the balcony for a while, a funny thing tends to happen. We begin to see that indeed there's no such thing as a dysfunctional system. The seemingly suboptimal or irrational behavior of people on the dance floor suddenly, reveals some sort of inner logic. It starts to reveal some patterns. So today we want to talk about identifying your key stakeholders in that gap that you've articulated for yourself. And I want to introduce you to another concept called thinking politically, factional mapping. And before we kind of get into that, that's the right slide. We can move on to the next slide. I want us to kind of start here to illustrate this point that we've made, since we started. If you're paying attention, I think you'll agree that when we think of power and where it comes from, and Peja and Sam will come back to this in later sessions, we tend to think of power as, flowing from the top and coming down. That's the traditional view of power, where you have the king of the hill, the chief, the Oga, the person at the top, and then the rest of the people are at the bottom, right? What we've been talking about for the past couple of sessions starts to kind of invert that triangle of power, where the person at the top is very unstable because you have these pillars of support at the bottom being all the different stakeholders, that keep that inverted triangle, standing. So depending on how you engage with people that are holding that upside down triangle together, you start to realize that the person at the top, or the authority, or the leader, quote unquote, is in a very unstable position. And the power actually flows from the bottom up. So I wanted to kind of start there by framing this conversation about thinking politically. Okay, next slide. So thinking politically refers to the ability to use this insight to mobilize key stakeholders. So rather than just trying to convince people, it's a profound shift as our focus becomes less about the problem, the challenge, right, itself, and more about the people's relationship to the challenge, to the problem. New and often kind of overlooked strategies emerge for how to engage people, to narrow that gap that we keep talking about. Because too often we try to mobilize people by developing a strong case, then marketing our idea as if leadership is just a big sales job. We then become frustrated when this approach doesn't create the buy-in, again, that language, or support that we expect from people. And we're confused why people just don't get it. All those people that we want to get immunized, why don't they just get the science, right? In fact, each stakeholder is a perfectly rational, in their own mind, of course, and distinct set of values, loyalties, and losses at risk that guide how they behave. And I'll say more about that, the values, loyalties, and losses, in a bit. So mobilizing stakeholders, that requires more than just clear value proposition and the shared purpose. It involves surfacing and moving forward amidst these competing and sometimes irreconcilable motivations. Leading adaptive change is deeply relational work, right? It's about relationship. Your relationship with key stakeholders is one of the most important factors in determining the results that you want to get. It's also why you can never lead alone, because there are other people, as we spoke, earlier. In the words of one of my colleagues, Eric Martin, who wrote Your Leadership Moment, when leading adaptive change, you can only move as fast as the people around you, right? The politics with a small p of engaging adaptive change can be difficult, particularly when people resist you. But avoiding the politics and it is unlikely to shift the status quo in any way. So you have to understand how to think politically and to create meaningful and impactful change. Okay, so let's start. Who are my people? A very important question to ask when you start to drive change. Who are my people? You remember last week we said, what is the work, right, of leadership, technical or adaptive? That distinction is very important. Today we speak about who are my people, right? Next slide. When mobilizing people, when driving change, I have always found it useful to engage people from a basis of their values, their loyalties, and their losses at risk. And what do I mean by this? Right, values, loyalties, and losses. That's one of the concepts that we'll introduce today. Adaptive leadership asks us to see leadership not as coming up with a good idea and selling it to people. That's marketing, right? But as being able to mobilize people from a standpoint of their values, loyalties, and losses, right? So next slide, please. We're going to look at these values, loyalties, and losses now. What are values, the VLLs? I'll start with the values bit. Values, as we define them, are what drives our behavior. You know what people value based on their behavior, not necessarily on what they say, you know, they value. It's based on behavior. That's an important thing to remember, right? And then what are loyalties? Anyone we or another stakeholder that we're dealing with cares about or feels beholden to or responsible for. You know, these loyalties make it hard for change to happen, to push for adaptive change, even when we want to, because we fear disappointing our people. Again, that concept that we talked about. So who are the people behind the people? Loyalties. And then losses. What a stakeholder might lose or give up by you narrowing that gap that we've been talking about. What could people lose if you narrowed that gap or if you close that gap? And these losses could include loss of identity. You're asking people to show up in a different type of way, right? Loss of competence. If you're changing the way things are done, that means some people are no longer competent, right? What they excel at has changed. Loss of comfort, loss of reputation, loss of time, you know, loss of status even, and sometimes loss of security. Right? All these are different types of losses that are at stake if you make progress on your on narrowing this gap. And we often make this mistake of thinking that people are afraid of change, that people don't want to change because it's difficult. And I want to propose to you that people don't resist change. People resist the loss that comes with change, right? Every change comes with some sort of loss. And if you don't understand what that loss is, then your work becomes very difficult. Then people's behavior then looks just irrational, right? And so it's important to spend some time understanding what values, loyalties, and losses each key stakeholder that you're dealing with has. Next slide, please. Okay, we've spoken to this. Next slide. And again, next slide. Right. So we're talking about losses. So it's very important even as we talk about these concepts, to think about the gap that you're trying to close, right? The gap that you articulated last week and that you've been working on. Think about the stakeholders that are involved in that gap, right? Think about their values, loyalties, and losses. Even as we go through this session, I hope you have a pen and paper close by and you're noting this down. So think about those people, whoever they may be that you work with. What are their values? What do they care about? As we define values here. Think about their loyalties. Who are they acting on behalf of? Who are their constituencies that they have to go back and report to, right? Think about the losses that might be incurred if you make progress. If you are successful, there's someone who's going to lose something. We're talking here about losses of identity, comfort, time, resources. When you gain, resources, someone might be losing resources. It might be competing for the same kind of pot of funding to make it, live. So who are those people in your case? And what are their values, loyalties, and losses? Think about someone who has a similar point of view to you, or a stake in the gap that you're trying to narrow. Someone who has a strong point of view, maybe, and shares strong ties to the people that you work with. They might not agree with what you have to say. Think about someone who has formal or informal power to affect the work that you are doing. Or someone who is affected directly or indirectly, who might be, affected if you make progress, or someone with something to lose if you make progress. Who are those people in your case? Elizabeth, let's just take down the slides for a moment. I want to see what's happening in the chat box, and see what people think. There's not much activity in the chat box. How is this landing for you folks? Does this make sense? Values, loyalties, and losses as a concept of how we think about, what people care about, the stakeholders that we're dealing with. Obiana, I see you. Dr. George, please don't call me a doctor. I haven't earned that yet. There's controversy right now in South Africa of people claiming to be doctors. I don't want to get into trouble. Okay. All right. It seems like folks are following. Great. Let's move. So values, loyalties, and losses, very important to understand what those are. Next slide, please. Okay, so it's also very important to understand the different players that you're working with. And what I want us to do now is identify, different factions and give you language for something different. So another kind of key concept that we'll be looking at. Now that you've kind of in your mind identified key stakeholders and have a sense of, with this hypothesis of values, loyalties, and losses, what they might view as important, let's get more tactical on how we engage them, right? And stakeholders tend to fall into what we want to call 6 key relationships, that's 6 categories, right? Or we call them factions. Factions are different ways of categorizing stakeholders in relation to what you're tackling, the challenge that you're tackling, that you've identified, that you want to make progress on, right? And narrowing that gap between where things are today and where you would like the system to be. This step is very important to insert between identifying your stakeholders and starting your engagement with them, because it's this relational aspect, that we're speaking about, of the situation that's essential to leading and navigating through complex situations, right? So let's consider what these key relationships are. I want to start with partners and allies. What you don't see on the screen there is allies. So who are these? Partners and allies are stakeholders with the most to gain if you succeed. So if you win, they win. The difference between partners and allies is that allies support your efforts, but won't take some sort of risk with you, right? While partners will put skin in the game. So it's important to kind of stay loyal to your partners and seek to cultivate allies and turn them into partners by incorporating, something that speaks to their values, right? Let me make this real for you. Say you have a very good time on a weekend, maybe too good at a time, and you find yourself in a jail cell, right? You've been arrested for having too much fun, and they give you the opportunity to call someone, right? The person that you call says, or picks up the phone first of all and says, "How much do you need for bail? I'm on my way, I'm coming." No questions asked. That's your ally, right? The person who's in the jail cell with you, that's your partner. That's your partner in crime, right? They're willing to go the whole way with you. They're willing to support you in a way that an ally might not, right? So it's very important to distinguish between the two. Don't expect your allies to behave like your partners. If you find yourself in a situation where you're confused as to who those people are, maybe you need to kind of think a bit more about values, loyalties, and losses. This is about your work now. And if you confuse your partners for your allies, those that might have very dire consequences. And it's not their fault. It's you failing to kind of distinguish between the two. So partners, differentiate them from your allies. That's the strategy that you need to kind of look at. And then opposition. Who's your opposition? Opposition are stakeholders who actively go against your progress. They actively get in the way of your progress, and they feel the loss that they'll experience isn't worth the purpose that you're trying to serve. They usually have the most to lose, and therefore they are the toughest faction to deal with, right? So as a strategy, you have to spend a lot of time with them, right? So this is not an exercise of naming people and making fun of them or anything like that, or demonizing people. This is an exercise in empathy. So if these people oppose you, what is it that they're opposing exactly? So by spending time with them, you get a sufficient understanding of what is the loss that they're avoiding, right? What would this change that you're trying to drive? What are they potentially losing? And they might see things from a different perspective that you haven't considered, right? Remember being on the balcony and observing different interpretations. They have an interpretation that maybe you haven't considered. So it's important to engage opposition. So with opposition, empathize with opposition. Try to find out what it is that they consider important. And then we have casualties. Casualties are stakeholders who will be left behind. Maybe they'll be fired or even disregarded in the name of progress. If you make progress, right? They'll be affected in that way. Many of us assume we can drive change with zero casualties, right? But that's really true. How you handle casualties matters, and everyone will be watching how you handle casualties. So it's important to treat them well on their way out. You'll relate to this sometimes in organizations when you have restructurings or retrenching. If you are in the same organization, watch how HR or whoever the authorities are, watch how they treat the people on their way out. You know, they'll probably treat you the same way, right? At some point. So it's important to treat casualties well, because they have a lot to lose. And then troublemakers, and I want to be clear here again that we're not just calling people names, right? Troublemakers are voices of dissent. They're people who consistently sound the alarm on the need for change. They typically want what you want, but they go about it in a way that might rub people the wrong way, right? They want the same results. And so the strategy here is to protect their voices. And you know exactly who I'm speaking about when you're thinking about your gap. This person that no one actually listens to, but they're right? They just have a very, uncomfortable way of rubbing people. But they want what you want. So it's important to protect troublemakers. They're mostly activists in the work that we do, but also make clear to them the kind of boundaries of your protection so that you don't become a casualty too, right? So protect troublemakers. And then authorities are your boss or other people who hold considerable formal and sometimes informal power in your organization. So it's important to watch them carefully to gain insight into what the system can tolerate. What change can the system tolerate? Right? Their power is not limitless, so they can only protect you to some point, right? There's authorities, and some of them are informal authorities. They don't have the titles, but they have the kind of influence to tank whatever you're trying to do. Right? So very important to understand who those people are, and also to watch for their signals. And then finally, the other relationship is yourself. The sixth key relationship is you and your own people. You also have competing commitments that'll affect your choices, right? So it's important not to become a casualty, first of all, to not let your passion for change make you a target, right? So be wary of criticism, or flattery, which are the two sides of the same coin. It's not personal most of the time when people oppose what you're doing, or they question it or they push back. Also, it's most of the time it's not even about you. It's about the change itself, right? So remember when we started, we said leadership happens at 3 levels, and it happens at 3 levels concurrently at the same time. It happens at the self level. What are your own values, loyalties, and losses, right? What are you afraid of losing? Who are you working on behalf of? Who is your constituency? Loyalties. And what are your values? What do you care about? Very important to be on the balcony of some of those things. So self, surround your community, your team, the ecosystem that you work in, and then system, the broader complex healthcare, national, subnational, funders, everyone coming in there. Think about those 3 levels that change happens on. So I want to kind of stop here or pause here, because we want to hear from Marion. Marion has a case that she'll share with us. And as she shares that case, I'd like you to pay attention to or identify some of these factions as she's speaking about them, because we'll break into small groups after she presents. And then in those small groups, we'll identify the values, loyalties, and losses of the different factions that are in Marion's case. All right, over to you, Marion.
No, before we go there, there's some really cool questions in the chat. So I just want to raise your...
let's take down the slide.
Yeah, it's there's a question like, when we say protect troublemakers, what do we mean? I think there's a difference between the troublemakers and opposition. It's still not a little murky for people. And then if you can clarify the difference between partners and the allies. So it's kind of like those are the 3 main things that were mentioned in the chat. I think really valid questions. So
Okay, great. Can I
Yeah.
take them one by one? Sorry, Pedro, I don't have full access to the chat box. What's the first question?
So what do we mean by protect the troublemakers? Like, what does it mean to protect the troublemakers? Like, what's the, if you can give an example or something like that?
Protect the troublemakers.
Yeah.
So I'm talking about protecting their voice. And, you know, troublemakers, like I said, are people that want what you want, but their way of going about it is, brings out, a response that's not ideal for the change that you want to make. So when I say protect troublemakers, it's about engaging them, right? About understanding what it is, that they care about, their values, loyalties, and losses, but also aligning in a way that uses their energy and their influence to drive your cause. But also remember that I said not only protect their voice, not only protect troublemakers, also draw clear boundaries for your own protection so that you don't also get painted as a troublemaker, right? You want the same thing. People listen to you because of your approach, probably. They don't listen to them because of their approach, but you want the same thing. So any kind of the idea of factional mapping is bringing people closer to you so that they become your allies and your partners. So that's the whole idea. I hope that makes sense. Pedro, you can add here also.
No, this is great. And the second question was about the difference between the partners and allies, and that's exactly where you were right now, where you ended. Like, so how is it?
Okay.
How to differentiate between who is a partner and who is an ally?
Okay. I always find that example that I made of finding yourself in jail very, if there's a better example, I'd like to hear it. But partners and allies, it's really about understanding what people are willing to sacrifice, on your behalf. You want to cultivate allies into partnership, because the allies are willing to go only as far as their own agenda, whilst partners are willing to put their skin in the game. So think about your relationships with your funders, for instance. Sometimes there's very clear parameters, for the funding that you get and the relationships that you have with your funders. And they may be partners or they may be allies. It's very important to distinguish between the two. If you find yourself in a situation where you have to go beyond maybe your funding. I'm just using funding as an example, right? I know it can be a difficult relationship, but those are people that kind of put resources into the things that we work towards. So the strategy is make sure you know who the ally is, make sure you know who your partners are. Don't confuse the two.
No, I can give a quick example. When we were doing some corruption work in Serbia, we were funded by one organization, like from US, and the moment we kind of like challenged the government, that's the moment when they said, like, we cannot do that because that can affect our relationship with the government, and we need that relationship with the government. So we knew that they're an ally, they will support us as long as their own interests are not at stake. And we respected that. Like, as long as you know that, that's good. You know that they will support you until their own interests are at stake. And the partner, we knew that they're not the partner, because the partner would be someone who will risk their own interests because they are actually working with you and they're fully committed. It's not like judging in any way. It's just good to know, because then you can plan accordingly. So, and then the last question was about I think the difference between troublemakers and opposition, like, how we can define that. There was a comment that troublemakers are opposition within our, is that true? Like, would that be a fair to say or no?
Opposition, I find it useful to think of them in terms of they also, you'll hear from Marion's case. There's a clear distinction between who the troublemakers are and who the opposition is, but these are not the same, right? Remember, and Peja, I think you've just kind of partially answered it. Troublemakers are in our camp, right? And again, it's not about us and them, but the opposition have a strong constituency that does not want to see you succeed in whatever change you're trying to make, right? And they have a valid kind of position from where they're coming from. So it's important not to disregard them completely. Yeah. I know we need to move because of time.
Yeah, just again, the comment about that, like when we were doing some cervical cancer like screening in Serbia, there were people who would say like, well, but we need to do all the screenings. Like we need to do the cervical cancer, we need to do the colon cancer, we need to do all of them. And that's the only way that can work. And we knew that if we kind of like go and do all of them, that we will do nothing because the government will say, oh, that's too much. So we had to kind of like protect them because their voice was the same as we are saying, like screening is important. But at the same time, we knew that we need to tell to the government, we are different. We are just interested in cervical cancer because that's something we can do easily and that's something it's worth doing. So that kind of thing, distinction is, I don't know if that's helpful, but that would be good.
Yeah, that's very helpful. Ade on the chat box, thank you for that breakfast, eggs and bacon. I see you're trying to get me into trouble. I won't go down that route, but you get it. Let's invite Marion back and ask that what my ask is that you note during her case, pay attention to the case and identify the factions. She'll speak to the factions, but think about the values, loyalties, and losses for each faction, because we will ask you to go into small groups later and discuss that. Marion, over to you.
Thank you, and good morning or good evening or good afternoon, wherever this presentation might find you today. Let me see if I can move the slides on my side. Elizabeth, would you move to the next slide, please? So today we're really going to discuss the target population, how you select the target population, and how you use the data that you have available, specifically focusing on vaccinating pregnant women. So why do we vaccinate pregnant women? I think one of the biggest benefits that we've realized is that we can protect the mother and the child during a period of vulnerability, where the mother has the ability to pass antibodies to the baby, either through breastfeeding or while the baby is not yet born. And it also links women with health facilities. I think that's a very important part because now women know how to access these health facilities. It will make them more likely to return to these health facilities for their child services that they would also require. But it also improves immunization coverage. It improves the health efficiency of the system. And it also improves the satisfaction and the demand from the community for health services. We've also found that women that receive antenatal care are more likely to vaccinate their children, which is really great. So it also improves childhood immunization services and access thereof. And then also it improves the cost effectiveness of our health system, not only by reaching untargeted populations. For instance, if the husband accompanies his wife that is pregnant to a health facility, we now have access to this target population that we might offer other health services or screening to. It also ensures saving within our health systems, and it improves the productivity of our health system as well. If we move to the next slide, the best reason why we have to vaccinate women is because it works. There was the study that was conducted in England and Wales in 2013 after an outbreak of pertussis in infants, and they started vaccinating pregnant women. And you can see this sharp decline in the incidence of pertussis cases after the introduction of a pertussis-containing vaccine during pregnancy. If we move to the next slide, then I just want to give you a history of how the immunization program, specifically for vaccinating with pertussis, started within South Africa. In 1974, we introduced the wholesale pertussis vaccine, and we vaccinated in the primary series at 6 weeks, 10 weeks, and 14 weeks, and we provided a booster dose at 18 months. After this introduction, we noticed a change in the disease burden, where the infants were mainly protected against the disease, but we saw a move in the disease burden to the unvaccinated population. So with high coverage of the pertussis vaccine, we saw that the unprotected populations now started having pertussis, although the adults or all the children getting pertussis doesn't have such severe outcomes. But we did see that children, adolescents, adults became conduits for infecting infants after they contracted pertussis. We also see in our context in South Africa that if you have HIV, and the children that have HIV has a greater risk of being admitted to hospital. So globally in the 1990s, the development of the acellular pertussis vaccine started. And that's really because the wholesale pertussis vaccine has a lot of serious or more serious adverse events contributing to poor completion of the immunization schedule. So the acellular pertussis vaccine is a more complicated manufacturing process, but at the end product contains fewer endotoxins and therefore has fewer side effects. Unfortunately, due to the way that the immunity work for either the acellular pertussis or the wholesale pertussis, the acellular pertussis doesn't give you such long protection against pertussis that we see with the wholesale pertussis. So in 2009 and 2013, respectively, we switched to the pentavalent vaccine that included the IPV into the South African schedule. And then later we switched to the hexavalent vaccine that combined the hepatitis B vaccine into a 6-in-1 vaccine that contained acellular pertussis. So in 2012, first the CDC and then later the WHO recommended that pertussis should be introduced into the pregnancy vaccination schedule. And in 2019, acellular pertussis vaccine was registered for use in pregnant women. So in the South African context, we are introducing the Tdap vaccine in 2024. If we move to the next slide, there's just a summary of what is pertussis. So I think the most important concept, all of us know what pertussis is. We know that it's a highly infectious or contagious acute respiratory infection that is also known as whooping cough, and that it's very dangerous to children, specifically under 2 months of age, that has a very high risk of hospitalization, more than 90%, and can also result in death. If we move to the next slide, we will look at the surveillance data from South Africa. So in South Africa, we have really good surveillance data. We have the National Institute for Communicable Diseases, and we have a surveillance program for pneumococcal disease. So we really do have good data, or for respiratory diseases. So we really do have good data that supports our program. So firstly, what we can see is that there has been a significant increase in the number of pertussis cases in 2022 and 2023. Even when compared to pre-COVID periods. So we can see for 2020 and 2021, there wasn't any cases or very few cases reported because of wearing of masks, but we can definitely see an increase of cases. So this increase can be an increase in the actual diseases, or it can be in our surveillance systems that have improved. We can also see that the detection rate for pertussis have increased since July 2022 to June 2023. And the number of cases is mostly in children under 5 years, with as much as 72% of those cases in children under 3 months. Now, just as a reminder, the children the younger children are at higher risk to have severe outcomes. If we move to the next slide, we can look at the actual number of cases that have been reported over time. And you can see from 2017, where there was only 17 cases reported, to 2023, where we are now, up to July in South Africa, more than 1,000 cases of pertussis have been reported. And on the next slide, we will get a breakdown of the age stratification. And we can see that the population at risk is under 1 year of age, the children up to 5 years of age, and then the group 5 to 9 years, and then the elderly population, people older than 65 years of age. On the next slide, then we will look at the recommendations from our National Advisory Committee. So in South Africa, we have the National Advisory Committee on Immunization, which is the South African NITEG. So the NITEG makes recommendations to the Ministry of Health, and then the Ministry of Health accepts the recommendation, or they might decide to delay the implementation of this recommendation, or they might reject the recommendation for various reasons. So the recommendation that was made by the National Advisory Group on Immunization, or NAGI, as we refer it to in South Africa, was firstly to improve the routine immunization coverage for the vaccines that are provided at 6 weeks, 10 weeks, 14 weeks, and 18 months, because we did see that a large number of these cases were in children under 5 years of age, and even in the population older than a year. So we know that these children were children that had access to the standard immunization schedule as well. They recommended that we should investigate or better understand the reasons for missed opportunities, and we needed to address them and have a catch-up campaign to ensure that all children that are eligible to receive a pertussis vaccine receive that vaccine that they have access to. And then secondly, to introduce the tetanus, reduced diphtheria, and acellular pertussis vaccine in the South African context. So two populations were identified. Firstly, the children were identified, and that the dose should be administered at 6 years and 12 years. And therefore, at 6 years and 12 years, we are switching from the TD vaccine to the Tdap vaccine. So what we should remember is that in South Africa, we are a self-procuring country. So currently we have a supplier for the TD vaccine, and this vaccine will be replaced by the Tdap vaccine. And we have not awarded the TD vaccine on the new tender again, meaning that that company that supplied South Africa with the TD vaccine will now in future not have the opportunity to supply that vaccine and may have some losses. They also recommended that we have to improve our routine immunization within health facilities. So historically at 6 years and 12 years, and I also touched on that last week, we have really bad coverage based on routine immunization within health facilities. Our TD coverage at 6 years is around 30% for the country annually, and then at 12 years is only around 15%. So obviously the way we are providing routine immunization services to this population is not ideal. And I can understand that because it's really not linked to any other health services. It's really focused on receiving these vaccines specifically. So there might be reluctance, not only from the children, but from the parents to return their children to health facilities, or they might not even know that these are very important vaccines to receive. So I've already touched on last week as well that we have a HPV school-based campaign where we vaccinate children in grade 5. And NAGI has said that the TD campaign that we're currently doing with the HPV campaign in grade 5, that should now switch to the Tdap vaccine campaign that will take place in grade 5. Then during pregnancy, we will switch from TT vaccine to 1 dose of Tdap in every pregnancy that will be administered between 26 and 34 weeks. And catch-up will be provided until the delivery of the baby. And it's going to be integrated into the existing basic antenatal care. And we're going to provide this vaccine at visit 3, 4, or 5. And then we're also going to monitor tools and also records to monitor the implementation of this vaccine. On the next slide, I will discuss how we have planned to introduce the vaccine by focusing on policy, program, and people. So firstly, in terms of the policy, as I've already alluded to, the National Advisory Group on Immunization has recommended the introduction of the Tdap vaccine. This vaccine, the recommendation was to the Ministry of Health. The Ministry of Health has reviewed the disease burden, has also reviewed the political opinion about this, the financial resources that are available, and they have agreed to introduce this vaccine. So obviously we can see that both the NAGI and the Ministry of Health are in an authority position. And then we also will continue our pertussis disease surveillance. We have existing systems, and I've indicated that The National Institute for Communicable Diseases have been doing a really good job, so we will continue the disease surveillance. We also have standard treatment guidelines for treating pertussis if a child did not receive the vaccine and is not protected, although we know that there's still poor outcomes, and that's definitely why we have to introduce this vaccine. We have also developed guidelines and to guide the vaccine introduction and to assist healthcare workers to understand the transition from the one to the other vaccine. So in terms of the program, we have 2 registered Tdap vaccines registered in South Africa. So we know that these vaccines are effective, we know that they are safe, and we know that they are of high quality because they were approved by our national regulatory authority. We also have the financial resources available. So the funding or the Tdap vaccine introduction will be funded through savings that we are making from a switch from PCV 13 to PCV 10. So there's no additional finances required from the provinces, which is great. And it's funded from the equitable share, meaning a part of the money that will be sent to the provinces that must be used for health services. And these vaccines were placed on a national tender. So a way for us to ensure that the vaccines are available and ensure security of supply, not only of the vaccines, but also of the ancillary items, is to place it on a national tender. The distribution of the vaccine is aligned with all of the other vaccines and will be distributed in the same way. We already know that there's sufficient cold chain capacity because we did a cold chain audit and we procured additional cold chain capacity already. The tools is available to record the doses that will be administered, and the waste disposal has also been considered. So in terms of program implementation, what is also very important to remember is that sometimes there are people that want people to get vaccinated, but there are people with different priorities. So a good example, for instance, is in South Africa, we don't do a universal birth dose of hepatitis B. We do a targeted approach. And that's because we are testing all pregnant women, especially with our HIV program. So mostly our Hep B positive population is known to us, so we can identify the children at risk. But for instance, when we did the training on the Tdap vaccine, in the commentary, we saw a lot of comments about, why are you spending such a lot of money on introducing this expensive vaccine? Because it is a costly vaccine, and not doing this not just giving a universal birth dose because it's a lot cheaper. So obviously we have the same objective. We want to prevent disease, and we want to ensure that children or people get vaccinated and that children are protected. But our strategies are slightly different. And I think it's important that you have to consider their opinion and, draw them in when the discussion about hepatitis B is going on, but not let it compromise the program that you want to introduce now, which is the Tdap vaccine in pregnant women. We also have people. So firstly, we have trained our healthcare workers, and we have developed a demand creation strategy considering the barriers to vaccination. Unfortunately, one of the biggest challenges that we have with our maternal vaccination program is a lot of these barriers to vaccination, specifically in this target population, is not known. And then we have different stakeholders that we had to engage with. So firstly, we have the WHO and UNICEF. They are obviously our allies in the process. They're willing to fund some of the trainings and, assist with development of training material, for instance. We also have different stakeholders in terms of, like the South African Society for Obstetrics and Gynecology. We have different specialist groups for pediatrics. So obviously they are definitely also involved in ensuring, they are also our allies. They also have the same objective, that they want to ensure that children are protected against pertussis. We also have different groups that really support us. I would say that they are more our partners, like SAVIC, for instance, which really assist us with developing of the training material, providing these services free of charge, really being there with us in the battle at the same time. And also VACFA is another good organization, really assisting the department to ensure that our objectives are met. If we go to the next slide, then I will focus on some of the challenges that we have. So as I've indicated, because this service will be integrated into health services, our health services are mostly ready. We are already providing basic antenatal care services. We have really high facility utilization of antenatal care. We also have high facility-based deliveries. So really, we will be able to reach our target population. That's all great. Okay, so our health facilities are ready. It will not necessarily take a lot of resources to implement this vaccine introduction. The biggest challenge might be that some of these healthcare workers will be taken out of their environment for training, and that some of the resources might have to be used for this vaccine introduction. But generally, our health facilities are ready and we are able to introduce this vaccine. But some of the challenges that we have is that vaccinating vaccine-hesitant individuals is really difficult to do. It is time-consuming and it takes a lot of money, not only to understand the vaccine-hesitant community, but to identify them. And this is one of the challenges that we have because currently we have very limited data about our existing maternal vaccination program. Only the influenza program is collecting any data about maternal vaccination. There is no data for the vaccination program of the tetanus toxoid vaccine. So it's unclear if we are reaching the entire population and where the populations are that we missed, if they're part of specific marginalized groups. So it's difficult for us to design demand creation strategy or even provide information to these groups if we don't understand their barriers to vaccination. And then in South Africa, we don't have an adult vaccination recording system or even a proper paper-based recording system for adult vaccination, which is a challenge because even if a person presents at a health facility after pregnancy, it would be difficult to identify whether she received the vaccine or not, because mostly these vaccines will be recorded within the maternal health record, and after delivery, that maternal health record is kept at the health facility. So that's definitely something that we have to work on as a program. If we go to the next slide, I just want to highlight this challenge that we have with the data that what we know about our adult immunization program. So this is the current status of our adult vaccination program with influenza. So you can see from 2018 to 2022, apart from 2020, when there was a sharp increase in the number of influenza doses actually administered in the country, there has been a decline in the consumption or the use of the influenza vaccine. So annually, there's a target population of about 16 million people that are eligible to receive the influenza vaccine, starting with children, the elderly, healthcare workers, persons with comorbidities, and pregnant women make up an estimated 1.15 million of this target population. The influenza vaccination program has various challenges, including supply, demand, and integration into health services. And therefore, from 2018 to 2022, it is estimated that the annual coverage is only 11% in pregnant women. So when we think about the strength of your immunization program and adding an additional vaccine to this immunization program, it should be considered how well your current immunization program is functioning. And if we only have this data from influenza, it's very difficult for us to understand why pregnant women are not getting vaccinated, whether it's due to the availability of the vaccine, whether it's due to the demand from the target population, or whether it's because of or the way that the service have been integrated into maternal care. So if we move to the last slide, I just would like to highlight some of the lessons learned. So firstly, evidence-based decision-making is extremely important, not only to select your target population, but also when you select a suitable vaccine for your immunization program, or when you design your service delivery model. Understanding exactly how you are going to reach the target population is essential. Implementation should be based on evidence, not only from surveillance, but also evidence generated by your own and other immunization programs. The target population informs your entire program. So you have to design your program to reach your target population. Even if you have the vaccines available, you have the resources available, you have the facilities and the healthcare workers available, but the vaccines are not reaching the people and the services are not provided in a way that is suitable to your target population, you will still have poor coverage. And that's exactly what we saw within the COVID-19 program as well. People wanted to get vaccinated where it was convenient to them. So luckily for the Tdap program, we are integrating it with an existing program, and we're likely to have success, but that definitely has to be monitored. And therefore, monitoring of your immunization coverage and surveillance within your immunization program is very important, and disease surveillance is very important. Remember when I said that when you introduce a new vaccine, there is some changes that happens in the disease profile within your community. So you have to monitor if the disease burden is going to move to another part of your population, and if you have to then implement strategies to protect that population that is now susceptible to the disease. So you have to identify the barriers to your immunization program and the barriers to access, identify opportunities for catch-up drives or for catch-up activities. You have to monitor disease surveillance and identify new at-risk groups. So it could be possible that once we have now introduced the Tdap vaccine into children and pregnant women, that group of people over 65, that had the very last peak of cases, that might now increase significantly, and we would have to then introduce an elderly vaccination program with the Tdap vaccine. But only the available data and our immunization coverage will give us that data. And then lastly, it's very important to consider health service integration to improve the efficiency of your health service and ensure that you have high levels of coverage. I think that is my last slide. Thank you. I think we're done.
Thank you, Marianne. That was brilliantly done. Thank you so much. I can hear the virtual hand claps. So now we're going to shift into small groups. You've been listening to Marianne share her case. Let's suppose that you are in a position to advise Marianne about what the values, loyalties, and losses of each stakeholder group are in her case. We're going to break into those small groups. You'll be sent into the groups. What you're being tasked to do, and because of time, we'll be back at 20 past the hour, so you don't have a lot of time. What you're being asked to do is identify for each. So if you're an authority in the group of the authorities, outline what you think the values of the authority in this case is, right? So remember what we said, values are things that people care about. Some of this information has been given to you already, and you will have a facilitator in your group. So what are the values? What are the loyalties? What are the losses? Come back with 2 of each. We'll ask your facilitators to report back in your group. So we're going to break into those groups now, and authorities.
Recording in progress.
Authorities. What were the values, loyalties, and losses that you identified for the Ministry of Health?
Yes, thank you very much, Nko. So in the group, people still had some challenges with trying to understand what values, loyalties, and losses were, but I tried to explain it. But one of the values that we were able to bring out from the authority is around protecting the public health, because the Ministry of Health and the Technical Advisory Committee, they are concerned about protecting the public health. And the other value is around evidence-based decision making. They want to ensure that when they make decisions, they have evidence to back this up. Then with respect to loyalties, the authority, they are loyal to the government. The Ministry of Health and the committee, they are loyal to the government, and they are also loyal to the people's health they are trying to protect. Regarding losses, the main loss that we're able to identify was around financial losses, which will have to do with procurement of the vaccines, as well as it was mentioned during the presentation that there was no data form for recording adults vaccination. The government may have to bring out the funds to produce this document. So the financial losses was the major thing that they would need to consider. So I think that was
Okay.
all we had before the time ran out. Thank you.
Thank you so much, Adunola. We're running out of time even now. Anu, your group was the opposition. Please give me one of each, one value, one loyalty, one loss.
Okay, so in our group, we identified religious and cultural as values that motivate anti-vaxxers, as that motivate them to become anti-vaxxers. Then also we identified the issue of peer group, religious leaders, peer group leaders, religious leaders that motivates them to become. Those are the people that are actually loyal to, and they provide the back-end support for them to become anti-vaxxers, and they're not going to be promoting vaccine. Why we identify reputation as something very major that they will be losing should they change their point of view in terms of allowing vaccination to take place among the pregnant women and other population. Thank you.
Wonderful. Thank you. Very, very important to underline those issues. Very important. Partners and allies, WHO, UNICEF. Joyce, what did your group think? One of each, please. Joyce, I think you need to unmute.
Yeah, sorry, I was muted. Yes, the partners and allies, we had WHO and UNICEF, and their value is mainly to increase equity among children and population, and the losses were mainly financial resources. That's what most people said, a waste of resources, and also aspects related to efforts and energy. The loyalties were mainly focused on providing support and resources to partners. That's what we had.
Okay.
Thank you. Mm-hmm.
Thank you, Joyce. In respect for time, I'll just ask Peja, your group troublemakers. We'll end with your group. Sorry for the other groups. It's just time is not on our side. Peja, what did your group think?
No problem. So we identified the sometimes local decision makers in community as a troublemaker because they share the same values of caring about the people. Like, so they are kind of like, they really want to see their people safe, but they also have the values of kind of like their own religion or culture. And then as a result of that, there's some loyalties to the rituals, to the practices, the usual practices that they're good to. And then as a result of that, we had a great discussion about the losses, because the losses would be that people rely on them so much that introducing a vaccine, especially in this particular way, they could lose that power. They could lose that reliance of their people. And we were just about to kind of like wrap up practical action as a result of that, but we couldn't do because it was a little short. So.
Tell you what, go to the Boost platform. I'd like you to share those there. And the same for the casualties and the group looking at Marion's own values, loyalties, and losses for a team. Please share that on the Boost platform. With the remaining time, I'd just like to share the homework that we're asking you to do. Please take some time in the next couple of days and think about your own challenge, the gap that you've identified. Identify the factions in relation to your challenge, those 6. What are those 6 key relationships in your own challenge? And then note down the values, loyalties, and losses for each faction for those 6. We'll share something, it's already being shared on the chat, a document that you can fill and then submit on the Boost platform. And also please take a brief survey that we have for you for the session. We love to hear from you, how the session went and what we can improve on and what you enjoyed, what you learned. And share those reflections on the learning group, on the Boost Learning Group, which you have access to. If not, just look at the chat box. There are those links there. And finally, please complete the self-paced module on building vaccine acceptance and demand for this week as part of the work that you have to do so that we can give you a certificate at the end of this course. If you don't do your homework. We'll have difficult conversations with you. Elizabeth, with the final minutes, anything else that you might have left out before we say goodbye to our colleagues?
That is it from us. We do have 1 minute left if the Tina's group or the casualties group does want to stay on, if anybody's willing to stay on for an extra minute to share those values, loyalties, and losses. But if not, that's all from our side of things.
So thank you, everyone. Let me just quickly share what my group said. For values, we value marginalized communities. We value reaching marginalized communities. We value coverage. And then from the losses, we are looking at compromising with other vaccines that may affect other programs. Looking at compromise and competing priorities, we are likely to have losses in such aspects. And then for allocating resources to programs, more than other programs can also affect other programs, like focusing on COVID-19 vaccination, and then the routine immunization program suffers. Then for loyalty, we were looking at Ministry of Health, being loyal to Ministry of Health, being loyal to our manufacturing companies who are responsible for pushing vaccines. And then also we are saying that we should be loyal to health beneficiaries, the health beneficiaries, which are the communities and the people that we are going to deliver the vaccines to. I think with this, I want to say thank you. This is what I can say for now. Thank you.
Thank you so much. I think that was all. And if not, we can continue the conversation in the chat. Forgive me if I have overlooked something, but thank you everyone so much for being here. And we look forward to seeing you next week. We will be following up, as we always do, with the recording, the slides, and links to everything that you can need for your pre-work and homework. So thank you so much, everyone, and I hope you have a fantastic rest of your day. Thank you.
Thank you and bye.
Thank you.
Thank you, and bye, everyone.
Thank you and bye.
Thank you. Bye-bye.
Bye.
Thank you, everyone.
Next
Bye,
week.
everyone.
Thank you, everyone.
Bye,
Next
everyone.
week. See you next week.
Bye.
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 Thank you. Bye.
Thank you, everyone.
See you next week. Goodbye.
Presentation. Thank you. Bye-bye.
Thank you, everyone.
Bye.
Bye. Thank you. Bye-bye.
Bye. Thank you, everyone.
Bye, everyone.